sir.
Thank
Thank you,
you.
Hindi team. Now we are moving to English session. Before beginning this session, we'll have a silent prayer. Today is our 1449th day of continuous webinar. So we are conducting this webinar without any break for continuous 1449 days. Thank you everyone for joining with us. Thank you all the faculties for sharing your knowledge. And today's our guest is Dr. GEETHA Jose. She's MD in Philosophy and MD in Materia Medica, BA in English Literature. She was a retired principal of Government Homeopathic Medical College, Calicut, and she was practicing in Karaparamba, Kozhikode for 10 years. And she worked as a HOD in the Department of Gynecology and Obstetrics, and more than 34 years of experience, clinical experience, and 32 years of teaching experience. And today's topic is PCOD and homeopathic management. Doctor, you're welcome to today's session, and you're already co-hosting. Okay, madam, you can start, please. I'm welcoming.
Thank you. Hello, thank you. Let me start.
Yes, madam. Yes. Your screen is visible.
Okay. See, today I'm going to take something about the management of PCOD. It is the homeopathic line of management of PCOD. See, polycystic ovaries or polycystic ovarian disease or polycystic ovarian syndrome. So that's the name of the condition. And here we have the common complaints as hirsutism, irregular menstrual cycle, obesity, acne, and subfertility due to anovulation. So hirsutism means the facial hair over upper lip, chin, breast, and thighs is seen in excess. And irregular menstrual cycle means it can be either oligamenorrhea or amenorrhea. Obesity means the waistline obesity. That is the body mass index, it will be between 25 to 30 kilograms. Acne appears, and along with that, subfertility due to anovulation. That is, the anovulation is a marked feature, and due to that, there will be infertility. Some patients have hyperprolactinemia, PCOS with obesity, and hyperinsulinemia, a greater risk of ischemic heart disease because of the low HDL level. If the ovaries are polycystic and USG shows features of cystic ovaries, it is called PCOD. In addition, in addition to PCO, other features like menstrual irregularity and infertility, then it is called PCOS or PCOD. Otherwise, it is called PCO. Then causes of PCOD. There is a change in lifestyle, diet, and stress. That is very, very important, this factor. That is the lifestyle, the diet, and stress. See, that means the patient should control the diet of the patient should be well controlled. That is, the lifestyle means the patient is assuming just going and sitting somewhere, always just lying down without any exercise. That is one cause for PCOD. Then along with that, if there is excessive stress and strain, that is the mental stress and strain that can be due to studies or due to some other reasons. If there is excessive stress and strain, that can later turn to PCOD. Then the lifestyle means the nature of the patient. That is very important. The diet means if the patient goes on with the junk foods and all, that's also one factor. the junk food that should be changed, that food should be avoided, and she should take the normal regular diet. Regular home diet is very preferable than the outside diet. That is, in the outside diet, the oil can be vegetable oil or some other oils or reused oils and all. Whereas at home, you don't use reused oil. That is one cause. Then genetic and familial factors. That is genetic, it can be seen genetically. The familial factor means one CYP21 gene mutation can lead to the occurrence of PCOD. Then obesity, adipose tissue is considered as an endocrine and immunomodulator. It secretes leptin, adenonectin, and cytokines. And this interferes with insulin signaling in the liver and muscle resulting in insulin resistance and hyperinsulinemia. Then raised RH secretion by insulin can cause infertility or miscarriage through improper oocyte maturation. So obesity is characterized by body mass index, which is greater than 30 kilogram per meter squared. And waistline hip ratio management is 0.85. Endogenous beta endomorphin also stimulates insulin release, which leads to insulin resistance. Insulin resistance with resultant hyperinsulinemia initiates PCOS in 50 to 70% of people through hypothalamo-pituitary ovarian axis, and adrenal glands are also involved. Then another is that insulin induces raised LH to cause thecal hyperplasia and secrete androgens, testosterone, and epiandrostenedione, which are converted to estrogen in the granulosa cell. And androstenedione are converted to estrone in the peripheral fat. This leads to estrogen and inhibin level, and in turn, high LH surge. While estrone level increases, estradiol level remains normal, resulting in estrone-estradiol ratio that rises. Then hyperandrogenism lowers the level of hepatic SHBG, so that the level of testosterone rises, leading to hirsutism. Androgen also suppresses the growth of dominant follicle and prevent apoptosis of smaller follicles, which are destined to occur naturally in the late follicular phase. Then endocrinological changes in PCOD. That is, estrone E2 level rises. LH increased. FSH remains normal, but FSH-LH ratio falls. And sex hormone binding globulin falls. Testosterone and epiandrostenedione rises. The fasting blood sugar, fasting insulin less than 4.5 suggests insulin resistance. Triglyceride level greater than 150 milligram per DL, hyperlipidemia, HDL less than 50 mg per DL. All these testosterone then prolactin level mildly raised. Say, these pictures show the polycystic ovaries on either sides of the uterus. You can see the polycystic ovary. Then fasting insulin. If it is more than 10 ml unit per liter in PCOS in 50 to 70% cases. Thyroid function test may show hypothyroidism. 17 alpha hydroprogesterone in the follicular phase greater than 300 mg per DL suggests hyperplasia due to 21 hydroxylase deficiency. Urinary cortisol less than 50 mg per 24 hours. So this is also, that is, see, this is the picture of the drilling of the ovaries. That is the allopathic management. I'll refer it later. both in the pathology, both ovaries are enlarged. If both are involved, ovaries show thick capsule of tunica albuginea. Ovarian surface may be thickened, but the peritoneal surface free of adhesions. Multiples is more than 12 of less than 10 millimeter, that is 2 to 9 millimeter size, are situated peripherally, the outer surface of ovary in the necklace pattern. This is got in the USG findings. Then theca cell hyperplasia and stromal cell hyperplasia are seen. Then the complications, that is insulin resistance, can lead to impaired glucose tolerance, diabetes, and then dyslipidemia, which is responsible for ischemic heart disease, cardiovascular accidents, development of cancers like endometrial cancer, ovarian cancer, and breast cancer. So these are remote complications. Then in the treatment side includes weight loss. That is the first and foremost thing, weight loss, lifestyle changes, exercise, and medicines. So these four are very important in the management of PCOD. See, weight loss, first thing. See, the overall weight of the patient should be lowered. That is, only when the weight gets reduced, the periods will get regular. See, weight reduced means simply weight reduction. We can't say simple weight reduction. That is, the patient should be asked to avoid junk foods. That should be, junk food should be avoided. Then ask the patient to take vegetables, fruits, and all. That is, daily the patient should take vegetables, fruits. Ask the patient to avoid the use of broiler chicken. That should be avoided. And instead of broiler chicken, and the egg of broiler chicken, that should be avoided. And the food should contain plenty of vegetables. Fruits should be included. Then excessive fat should be avoided. Excess fat should be avoided from the food. Then the oil should be, it's purely coconut oil is better. So ask the patient to avoid outside food. That is, the hotel food should be avoided and the home food should be adopted. So that is the weight loss. And lifestyle changes. Lifestyle changes means the patient going and sitting somewhere or just sleeping off for a longer time. So all those things should be avoided. The patient should be active, always active, and the patient shouldn't go and sit or stand somewhere like that. The patient should always be active mentally and physically. The patient should be active. Then exercise. Exercise is one important factor. The patient should do daily exercise. Exercise should help that will help the patient to balance the weight loss as well as the lifestyle changes. This can be managed by exercise. Then comes the medicines. What are medicines we can use? See, this is a picture of the yoga which can be adopted in. See, this is the picture of. Before going into the case study, I'll just show the medicines that can be used. So these are the common medicines that can be thought of in PCOD. See, trillium pendulum is one medicine. That is, in the patients, you can get hemorrhage at times. That is, whenever there'll be irregular menstruation, and along with that, if at all menstruation occurs, sometimes it can lead to excessive bleeding. So that is the picture you come across. So here, trillium pendulum is simply one medicine that you can give for excessive bleeding. Then another medicine is used lango for excessive bleeding. Then sabena is still another remedy that can be used for excessive bleeding. That is, there'll be severe back pain as well as the bleeding tendency will be there. Then platinum metallicum, that is another medicine where you can think of in PCOD patients. Naxomica, another medicine, still another medicine, which can be given for excessive profuse bleeding. There is too early, too profuse, last too long. So such a condition occurs in Naxomica. Then lactifloratum, another medicine. See, by putting hands in cold, drinking a glass of milk will probably suppress flow until next period. In cold water, if the patient puts their hand, that can lead to. Then conium mac, that is for PCOD condition where the patient will be having vertigo. Almost at all times there will be vertigo in such patient. Then euphrasia officinalis. This is painful menstruation and lasting for only 1 day. Glonoin, still another medicine. Then graphitis, another medicine. Sabelserlitum. See, it is for the development of the ovaries also. It's a very good medicine. Then Sabedilla, another medicine. Restox, that is for ovarian functions. To control the ovarian functions, Restox is another medicine. Then Pulsatilla, another medicine for suppressed menstruation, too late, scanty, dark dotted, such changes. There is in Pulsatilla, there's a type of dysmenorrhea. The patient will be having severe pain, and along with that, the patient will become very chilly during the time of menstruation. When severe pain, more the chill. Then podophyllum, still another remedy. Sepia, another medicine. So it's a very good medicine. Dark, rigid hair. So the patient has contradictions, always contradictions, indifference to those whom she loves, especially to whom she loves best. Then natramor. See here, the patient is anemic, cachetic and all. Then headache from sunrise to sunset. Then calcaricum, another medicine. Too early, too profuse, too long lasting. And now we'll go on to the cases. These are the cases. See, the first case, it's a 35-year-old woman, and she has PCOD since 16 years. So she had regular periods for the first 2 years of menarche. After that, the periods became irregular once in 3 months and flow lasting for 21 days. So she took allopathic treatment for the bleeding. PCOD was diagnosed at the age of 19. Gradually, periods got regular. Flow lasted for 10 days. Then she got married at the age of 28, had difficulty to conceive and got pregnant. She had gone for the ICSI treatment at the age of 34. And she had a child, and 4 months after delivery had heavy bleeding, just stopped by allopathy. And now heavy bleeding since last month. She came to me with heavy bleeding. See here in the HPI, she had chickenpox, childhood tonsillitis, then treatment history, allopathic treatment. Family history was nothing relevant. Personal history, born, brought up at Wayanad, BSc nursing, married. And she has 1 child. Sickle generals, appetite good. Thirst, drinks 3 liters per day. Prefers cold food and drinks. Sleep good. Dreams nothing particular. And bowels often constipated, hard stool. Urine no complaint. Sweat increased more on face. Desire sweets, chocolates. Aversion sour. Intolerance nothing particular. Thermal, hot, prefers fanning. And the mind is, she's irritable, easily angered, shouts, emotional, weeps easily depressed. She has laziness, takes time to start her work, weakness of memory, often forgets, and craving for sweets, often. Then menstrual history, irregular cycle since 1 year, increased bleeding, flow, passage of clots. Before menses, pain in breast, mood swings, low backache, cramps in legs. Then during menses, low back pain during first 2 days of menses. And PMB was 27, 11, 23. And LMB 1, 1, 24. And the obstetrical history, you can see one child, then labor at the age of 32, and she had done ICSI, gone for ICSI, and regionals, low back pain since the age of 15, aggravation during menses, morning on rising and urination exertion. Bleeding stops only by allopathic medicines. And in the therapeutic side, on 4/1/24, she was given Phytolacca 30 1 dose. The reason was to stop, since she was under allopathic treatment, after allopathy, when a patient comes, it's better you give Phytolacca to control the bleeding. So here, Phytolacca was given. And on 22/1, she had a bleeding per vagina from 9/1/24. It lasted for 19 days and stopped after taking amamless tincture 5 drops twice daily. And on 19/4/24, there was increased vaginal discharge, itching vulva. So PSOD 30, 1 dose was given. And on 23/7/24, there was amelioration of vaginal discharge, bleeding lasts for 7 to 10 days. During each menses, PSOD 200, 1 dose was given. We'll see here, it's better you give the medicine in a single dose, and it's a minimum dose. I suggest minimum dose. And see here at first on 4/1 it was given, then 22/1 when the bleeding occurred, then 19/4/24 given, then 23/7/24 creosot 200 was given. So that's with the first case. Then second case. Here a lady aged 24 years. PC irregular periods 2 years. Periods once in 4 months. Profuse flow lasting for 7 days. Severe pain. There was vomiting during the flow. Then sudden increase in body weight. And now since 5 to 6 months, patient is under allopathic treatment with regular flow. There was acne on face. Then family history, mother has hypothyroidism, and personal history, occupation, teacher. Then the physical generals, appetite good, thirst good, sleep disturbed, desire pungent, aversion pizza, burger, and all. Then intolerance, tubers, jackfruit causes flatulence, bowels, hard stool, urine, nothing abnormal. Then sweat generalized, thermal, hot patient. LMB was on 4/1/23. Mind, irritable, easily angered, mood swings, indifference recently, easily tensed and angered, shares complaints only to a few selected persons. And regions migraine, bitemporal, feels like hammer striking inside the head. Aggravation sun heat, aggravation vomiting. Numbness of hands and feet, aggravation night since 1 year. And on UST, the uterus was antevoted normal size. Both ovaries show multiple tiny follicles arranged peripherally, the central echogenic stroma, minimal fluid noted in pouch of Douglas, and endometrium 5 millimeter. So the diagnosis was bilateral polycystic ovarian morphology. So the first prescription was on 7/1/23, Natamor 31 pill. See here, I have used 10 size pill. And the second on 14/2, SL and BT was given, and 14/3 also SL and BT. On 14/4/23, Natamor 200 1 pill, 10 sized is given. Then 14/5, LMB 1/5/23, SL 4 dose, BT 1 month. And on 14/6, the LMB was on 31/5 and SL and BT 1 month. 15/7, LMB was 1/7. And Natamor 1 dose, 10 cents was given. And 15/8, the LMB was on 29/7. SL and BT was given. And 14/9 also, LMB was 26/8. SL and BT was given. And the case improved with occurrence of regular periods. In this case, it was that of a 15-year-old girl. PCO was the diagnosis since 2 months, and HPC regular menses since 2 years. Sometimes periods occur twice per month, and sometimes amenorrhea by 3 months. Profuse bleeding lasting for 7 days or scanty menses. Blood is either dark brown in color, pain lower abdomen, low backache, and down the legs. 4 days before menses. Pain breast 4 days before menses, headache and nausea during menses. Hair growth on face and thighs, and hair fall from head 2 years. Increased vaginal discharge 1 year, whitish jelly-like or whitish curd-like discharge. The itching of eyebrow. Then HPI premature. She was a premature baby born at 7.5 months. And family history, father had diabetes, hypertension, dyslipidemia, and cardiac complaints. Mother, uterine fibroid. And here, the physical generals, appetite increased, thirst increased, sleep good, dreams with fearful dreams, occasional constipation with unfinished sensation, urine increased, sometimes ineffectual urge. Sweat normal, generalized, desire chicken omelette, and thermal was chilly. Menstrual history, irregular. 2 years, either twice or once in a month, or amenorrhea of 3 months. For 7 days, sometimes profuse or scanty, dark red or brownish, pain back, legs, and pain lower abdomen on first 4 days, headache and nausea on second day of periods. Then she's easily disturbed and she has a crying tendency, is very sad, doesn't share her feelings, prefers to be alone, aggravation noises, and causes irritation. She is uneasily anchored. Regionals, headache, pain frontal and parietal regions with nausea, aggravation, sunlight, traveling. Eye strain causing watering of eyes, recurrent attack of cold and fever since 1 year. After COVID affection, aggravation, cold climate, and cold weather. Allergy to dust causes itching and watering of eyes. Then phrinoderma, both elbows. Costochondritis, constant pain, 3 months. Pain left eye, 1 month. Then in the USG, the finding was that myometrium was homogeneous, endometrial thickness 6.9 millimeter. Then right ovary 3.1 into 1.8 into 2.1 centimeter. Left ovary 3.4 into 1.9 into 2.6 centimeters. About 3 to 5 millimeter size multiple peripherally arranged follicles in bilateral ovaries. Largest 9 millimeter size follicle in left ovary. And the impression was PCO, both ovaries. On lab investigation, the fasting blood sugar was 102, then testosterone 0.28, LH 17.5, FSH 3.9, prolactin 24.5, and TSH was 1.48. And the first prescription was Sepia 30, 1 dose. And that also was given in 1 pill, 10 size. And on 3-2, she used to get frequent attacks of fever. Now no fever, LMP 4123. 8 days flow, and SL 4 dose, PT 1 month was given. Then the next medicine was on 12-4-23, LMP 13-3-23, and the PMP was 4-2-23. Sepia 200, 1 dose was given. That also 1 pill and 10 size. Then 12-5-23, LMP 17-4-23. Disturbed sleep, must sigh, at times deep sigh, Calimos 6X is given, 1 dose. Then 36-23, LMP was 22-5-23, stopped on 29-5-23. Then 13-7, LMP 29-6-23, 7 days normal flow, offensive breath, and sepia 1 1 dose was given. Then 15/8/23, PMB was 16/7/23, stopped on 18th. To repair on 24/7 as candid, stopped on 25/7, pain lower abdomen for 2 days. So NP was given, 661 pill was given. Then on 15/9/23, LMB was 17/8/23, flow lasted till 25th, pain abdomen, and on first 2 days, cough, no expectoration. So Calimore 661 pill was given, which is continuing the treatment with flow every month and to be continued with an anti-miasmatic remedy, Medornum. Medornum can be given later. In the next case. So she's from Cheruvulam. Then PC was irregular menstruation since 5 years. HPC periods was once in 2 months. Initially, bleeding used to be scanty. And she later in 2022, May, she got a flow lasted for 14 days. Took homeopathic treatment. Following this, the periods reappeared. Now the periods is regular, 7/21. Since 4 months, heavy bleeding. Flow lasted for 6 days, followed by spotting of brownish intermittent flow. Pain lower abdomen starts on first day and lasts up to 5 days. And pain starts 2 days prior to periods and lasts for 3 days. Occasional aching of abdomen, leukorrhea, fins menarche, profuse white jelly-like offensive discharge. In family history, father is hypertensive, mother has uterine complaints, fibroids, took homeopathic treatment. And the personal history, physical generals was appetite decreased, prefers warm food and drinks, does good, sleep, dreams, fearful dreams of snakes, pearls once in 2 days. Then urine unfinished sensation. Urge is there, sweat, normal, and offensive more on upper lip. Desire pungent, spicy food. Aversion, nothing particular. Intolerance, fast food causes pain. There will be nausea and belching, thermal intolerance to extremes of climate. And mind easily angered, easily sad, and cries, desire to be alone. Regional headache, pain, forehead, aggravation, sunlight, recurrent attack of the mouth, tongue pain, painless white colored, recurrent attack of abdominal pain on upper abdomen, nausea and belching 2 years. Hair fall 5 years, dandruff, powder eating. Cervical rib right, pain extends down the arms to fingers, drawing sensation. Aggravation lifting weight. Pain upper back 1 year, aggravation sitting, aggravation breast. Recurrent attack of UTI 6 years. Pain urethra with frequency of urination, yellowish urine. And fever sensation 1 day with chilliness and headache, frontal region and pain legs. USD pelvis on 9/5/22, uterus antiverted, antiflex 6.6, 2.9 into 4.4 centimeter. Myometrium homogeneous, endometrial thickness 7 millimeter. Right ovary 1.6 into 1.9 into 3.3 centimeters. Left ovary 1.8 into 2.8 into 3.9 centimeter. Both ovaries show peripheral follicles, peripherally arranged follicles and thick cogenic stroma. Follicle count greater than 12 on both sides. So there is PCOD bilateral. Then the T3 was 1.14. T4 10.98 and TSH 1.756. The prescription, she was having fever, chilliness and cough and all. But that Naxomica 31 pill was given in half a glass of water to be taken. And on 13/10/22, she came with spotting of blood on 1/10/22 and again on 8/10/22. LMB was on 20/10/22, 9 days. So SLNBT was given. Then The LMB 10, 11, 22, no pain, scanty flow. SL and BT was given. Then the bleeding had stopped on 15, 11, 22, followed by blood-stained discharge. So a brown color discharge from 25, 11, 22 after the mouth was aggravated, increased salivation. So Maxol 31 dose was given. It was 10 size pill. Then 30, 11, 22 brown colored flow persisting. Use Flago tincture 5 drops once is given. Then on 29, 11, 22 bleeding stopped on 12, 12, 22. And allergic rashes on body with the central spot. So the blood HB was 10 gram, DSR was 25 millimeter, eosinophil was 6%. Borax 3x 1 dose was given and BT 1 month. And 25 to 23 spotting of blood had occurred from 7/1/23 for which allopathic treatment was taken. Just having craving for raw rice, cannot tolerate heat, prefers warm food and drinks sleep. So Pulsatla 31 dose, that is 40 size was given with BT for 1 month. And on 1/5/23, bleeding was scanty, profuse had occurred from 23/3/23 and had stopped. So they used Lago 30, 5 doses were given, 40 size pill. So 5 pills were given once in 4 days. Then on 1/6/23, no spotting, but quantity of blood increased. UTI was frequent. So Pulsatla 201 dose, 40 size pill was given with BT for 1 month. And on 4/7/23, she had UTI, urine routine examination, RBC 3.3 to 5 per HBF, epithelial cells 4 to 6 per HBF, albumin faint trace was given. Then headache at times, pain frontals, LMB 10/6/23, severe pain for 3 days. Trace raw rice on examination, pallor was seen. So anatomor 6x 1 dose was given. BT 1 month. Then 7/8/23, LMB was 24/7/23, 3 days, no pain, had coryza. So anatomor 6x 1 dose. And BT 1 month was given. 11/9/23, LMB was on 27/8/23, 3 days flow, followed by scanty flow for 7 days. Then there was increased vaginal discharge, whitish curd-like itching, offensive. So Sepia 30, 1 dose was given. BT 1 month. So on 11/10, the LMB was on 2/10/23, no periods in September, 3 days flow, increased vaginal discharge, not offensive, no itching. And Califo 6x 1 dose was given with BT 1 month. So now she's continuing the treatment. So that's with PCOD. So this is the acanthosis nigra. Nigricans that you can see the pigmented skin over nape of neck, inner thigh and axilla due to insulin resistance. This is seen in insulin resistance cases. And here you can see the polycystic ovaries on either sides with the uterus. So here this is, you can see the left polycystic ovary. So that is after ovarian drilling. You can see the right polycystic ovary after ovarian drilling. See this drilling procedure that is done in allopathy. And that is in cases of PCOD. And they want the patient, that is especially when the patient wants to conceive, to remove this, they have no other management. So with the help of laparoscope, they do the drilling procedure. By drilling, they just rupture each follicle. Each follicles are ruptured and the patient is asked to conceive immediately. Immediately they give the medicines and for ovulation and they ask the patient, make the patient conceive immediately. but the consequence of this is that this can lead to there is sticking between the sticking of the structures. That is, there is a fixity is likely to occur. It's a complication of this drilling procedure. This is the exercise to be, this can be practiced for PCOD. And this is the diet, normal vegetable, fruits and all. Milk diet. The peripheral follicles are seen here. Follicles are seen in the periphery. And thank you. So if you have any questions.
Now we have 15 minutes per question. Those who wanted to ask to Dr. Geetha, you can hand raise and we'll ask the question. Thank you, Dr. Geetha, for your evidence-based recorded case presentation. Actually, many are struggling to treat the PCOD. Now, you are very easily cured many cases and recorded it for the for to show the other generation also. It's a great achievement for the homeopathy and proud for us also. And doctors, please, those who have questions, you can ask, please.
For me, usually after the patient comes with the allopathic treatment, I start with with phytodeca. And usually each treatment is stopped with anti-miasmatic. We should.
Okay. Phytodeca, which potency?
Phytodeca 30, 200, 1. And don't repeat the medicines too often. So I keep a gap of 3 months between each medicine, each dose of medicine. So in between, if you want, you can give biochemic, a single dose. 1 pill can be given.
Yeah, that is the magic of homeopathy. If we are repeating and giving more doses of medicine, it will overdose. And this acanthosis nigricans, mostly now the kids and many are showing this symptoms. So they are insulin resistant, and if they are prone to PCOD also.
Yeah, there is see in females, if it is seen, they will be prone to PCOD.
So can we treat before they are showing the other symptoms? Can we treat? I mean,
we have just medicines now which shows symptoms of acanthosis. So you can treat them if they have anything. Just treat them. So you can prevent.
Only to treat the medicine for. I mean,
the general case. Always the case taking is always very important. Take the case properly and give the medicines. So
nowadays every kids are obese and they have acanthosis.
Obesity.
Yeah. So it is insulin resistant and they are prone to this also. Okay. Actually, when beginning the questionnaire, it is very difficult to start the questions. When we are ending up the session, it is very difficult. And it is, everyone will come and ask question. Dr. Ram Parvesh sir, you have some question. He put some question.
Thank you, Dr. Anjani. And congratulations, Dr. GEETHA Josh Madam. Very nice presentation. Excellent session. Evidence-based presentation. Yes. Very good. This is beauty of homeopathy. According to homeopathic philosophy, select remedy and correct symptom. I am very glad. I am very agree, Dr. Madam. Very, very thanks, Madam.
Okay, thank you.
Very, very thanks.
Thank you, Dr. Parmesha.
PCOD, according to miasmatic role of miasmatic, endocrine glands, deficiency of endocrine glands and electrical disbalance, background of pura, functional and psychotic miasm. Sudha is the best remedy. And Sudha is the best remedy. Very, very thanks.
Thank you.
Thank you, sir. Thank you. And anyone else? If you have any questions, you can ask.
And here when the bleeding occurs in between, when it's very profuse, you have to give the anti-miasmatic remedy. That is the case, and that is you take the family history of the patient. So there you get the spot out the anti-miasmatic and give the anti-miasmatic at that time. Then you'll be able to do it.
Dr. Fahad Shahzad, okay, you can ask. You can unmute yourself and ask. Please. Are you again muted? Huh? Please unmute.
Yeah, Assalamu alaikum, ma'am.
Walaikum salam.
First of all, thank you so much, Dr. Geetha, for your sharing such a beautiful knowledge and your experience as well. Because we used to say experience never fails. Your research, your books can be failed, but your experience can never be failed. I want to add some points regarding that PCOD, because I have got some cases like in females, especially in PCOD. The most important factor in PCOD is androgen. If you will concern or look into these medicines, you have discussed like phytolacca, like Nuxvomica, and whatever the medicines you mentioned in that case. If we will focus in these medicines, we will get through that. There are some symptoms like obesity and hair fall. So these symptoms, if we will match these symptoms with the androgen is a hormone that is mostly present in a males. But in PCOD cases, normally female passes through a normal menstrual cycle phase. In PCOD, the ovary start producing, we can say malfunctioned eggs, or we can say the defected eggs that can cause the production of cyst in the ovaries. So if we will look into the androgen, then we can easily you can say diagnose a case of PCOD in females, because in most of the cases when we ask or taking a case from a female, we used to note that female mostly say that he is gaining weight, obesity, and maybe most of the females pass through the hair fall pattern. You have discussed in one or two medicine like alopecia. People, there is a symptom of alopecia, that's why you suggest a different medicine. And due to the obesity in PCOD patient, we recommend them a different medicines. So androgen is a main factor. If we will analyze androgen in the start of this case, we can easily go to the direct finalized diagnosis. Like if we will differentiate between PCOD and PCOS, mean polycystic ovarian disease and polycystic ovarian syndrome, we will examine that in PCOD, the cyst produced in the ovary moved outside the ovary. But in PCOS, mostly, the cyst produced in the ovary wouldn't able to move outside the ovary. that is due to the production or excess production of androgen, because in PCOD, our glands like endocrine glands, as the doctor mentioned, that endocrine gland start production of androgen, and due to the excess production of androgen, females mostly pass through the hair fall, and the hair fall pattern will be like in a male. That's why most of the medicine used in the PCOD also cured the alopecia, or also cured the hair fall disorder. And if you will focus on this medicine, these medicines are also used in obesity. So in my point of view, as you have mentioned that, I'm not disturbing your lecture. Sorry if you mind that, but I just want to highlight the importance of androgen in this PCOD. So thank you so much. That was my key point for the new beginners, because I know the doctors who are listening these lectures are more experienced than my age. I am not able to ever compare your experience with the knowledge. So sorry if I am wrong, you can mention me clearly in this point. But I want to highlight the androgen. And thank you so much again, ma'am.
Thank you.
Thank you, Dr. Shahzad, Fahad Shahzad. Where are you from? From Pakistan?
Yeah, ma'am. Actually, I am from Pakistan, and I am the first licensed homeopathic doctor in Qatar.
Oh, Qatar. Now you're working in Qatar. Okay.
No, I'm working in Qatar.
Okay. Okay. Thank you, doctor. Thank you so much.
Thank you.
And now, now I am inviting Dr. Subaida. Dr. Subaida Salam. She's here. Doctor, can you raise your hand? I couldn't find you out. Where it? Dr. Hariharan have question. Huh? Okay, doctor, you can ask.
Hello. Hello.
Okay, doctor, you can ask. If Dr. Subaida is there, please raise your hand. Okay, doctor, you continue. Dr. Hariharan can ask. Yes,
okay,
you are
doctor.
audible. You are audible.
Doctor, I'm not fully heard your class, but last I like to ask a question regarding. See, for insulin resistance, see, what is your opinion regarding cinnamon?
Cinnamon. See, I take the case. I don't prefer any single medicine as such. I take the case and give the medicines according to that.
Only you are not using any pathological remedies.
No,
Am I correct?
I never use.
You never use.
Yeah.
Okay, good. But in my opinion, in my practice, I am using the constitutional medicine along with pathological medicine, giving a very good result. Formerly, in my early practice, I used only the constitutional medicine, but I am getting better result after using their certain pathological remedies. See, Amna Vishaka, the cinnamon, like other medicines, if you go, this medicine according to symptoms I will give, and I am getting very good result. You can also you try to research this type of application, and you will get very good result. And see, for what if for AMH, treatment for AMH, how is your practice? How is your way of approach? Can you tell me?
Yeah, AMH is we say go for AMH only for cases that go for IVF and all. But we are not going for IVF.
Madam,
For
see,
IVF, that's important.
See,
important.
Okay, madam. But in certain infertility cases, see, a lady came 40 years, very low AMH. But see, now she became pregnant and delivered a small baby. See, so we can treat low AMH cases also for infertility. Along with this, I like to convey this information only for you, only for the information regarding. That's all.
And my answer is that say AMH is seen only in cases where you go for IVF. And we are not going for IVF or anything. We are going for natural conception and all. So here AMH is not that much important. Only if you go for IVF that becomes important.
Okay, doctor. Okay, now we are it is the time for the Malayalam session, and now I am inviting Dr. Abdul Salam sir for giving vote of thanks to Dr. GEETHA Jose. Actually, I was about to call your classmate Dr. Subaida, but she's I think I couldn't find her out here. So Abdul Salam sir, please. He's also doctor. Sir, please unmute yourself.
She is with me. She will help.
Ah, okay. both of you give vote of thanks together.
Okay.
Good evening
Okay.
to all. Dr. GEETHA, she is my classmate and she was my colleague. And I don't know what to say because she has showed her excellence in our college itself. And I feel her retirement from the college is actually a great loss for our students. Anyhow, I don't want to talk more. At this moment, I would like to show our gratitude and thanks to her for sharing her experience to the IFPH members and also for the other public, because these videos are sent in the group also. So thank you for sharing your experience in this moment. Thank you on behalf of IFPH.
Thank you, Subaida.
Thank you. Now we are moving to Malayalam session. Thank you everyone, and thank you Dr. GEETHA for your humble attitude and presentation. Love you so much. Thank you.
Thank you. Okay, thank you.
Thank you. Now I'm inviting, who is moderating today's Malayalam session? A good night to everyone. See you tomorrow, the same time. Now we are moving to Malayalam session.
Mariamma John.
I'm inviting Dr. Mariamma John for, where is she? For moderating Malayalam session. Doctor, you are the co-host now. You can start. Thank you. Dr. GEETHA, please, can you stop sharing the slides?
Okay, I'll stop.